Hello, I'm Dr. Stephen Gabarty. On behalf of CME Outfitters, thank you for joining us for this CMEO snack series entitled Navigating the Mycophenolate Rems, an interactive approach for the interdisciplinary care team. This activity is supported by an educational grant from the Mycophenolate Rems Group, a consortium of more than 25 companies working to communicate and mitigate the risk of embryo-fetal toxicity associated with mycophenolate use during pregnancy. This is the first of 3 CMEO snacks and will cover the clinical uses and serious risks associated with the mycophenolic acid preparations. Again, I'm Dr. Stephen Gabarty. I'm an abdominal organ transplant clinical specialist at Brigham Women's Hospital and an assistant professor of medicine at Harvard Medical School, both in Boston, Massachusetts. I'm very pleased to be joined today by Dr. Mie Kim. Dr. Kim is a colleague of mine at Brigham Women's Hospital in Boston, where she is a clinical pharmacy specialist at the Center for Advanced Heart Disease, working specifically with heart transplant recipients. Welcome, Dr. Kim.
Thank you for inviting me, Steve, to talk about this important topic today.
Here's our learning objective for today's program. After participating in this activity, learners should be better able to evaluate the pregnancy and fetal risks related to mycophenolic acid use. Okay, let's jump into this. I think it's important before we discuss the mycophenolate Rems, we should first discuss what mycophenolate is, how it works, and what its indications are.
Sure. Mycophenolate or mycophenolic acid, we often call it MPA, is one of the most commonly used immunosuppressants after receiving solid organ transplant. Its derivative has received an FDA approval for its use in preventing organ rejections in kidney transplant recipients in 1995. For a little bit of history of this medication that I found very interesting was that the drug compound has been around for a long time, was in fact the first antibiotic that has ever been purified from any source. It goes way before the discovery of penicillin, as early as in 1893. It was obtained from mold, therefore was given its name mycophenolic acid, which means an acidic phenol obtained from a fungus. Since then, it has been rediscovered in multiple occasions by different groups of scientists as a possible antibiotic, antifungal, antiviral, and anti-tumor agent. But it was quite toxic. Even it was once considered as a mycotoxin, as it was found lethal in some doses in animal studies. It was not until the 1960s when its immunosuppressive property was identified. MPA exerts its immunosuppressive effect by inhibiting an enzyme called inosine 5-monophosphate dehydrase, IMPDH, which is involved in de novo biosynthesis of guanine. Organ rejection is mediated by lymphocytes via their activation and proliferation. Since proliferation requires DNA synthesis, inhibiting the formation of its building block, which is purine monophosphates in this case, can prevent organ rejections. Its inhibitory effect is somewhat selective in lymphocytes, as they are particularly dependent on the de novo biosynthetic pathway, while other cells can recycle purine through salvage pathway. It had not been commercialized until a novel mofetil ester prodrug, mycophenolate mofetil or MMF, was developed, which has improved absorption. MMF, mycophenolate mofetil, is available as an oral capsule, tablet, suspension, or IV injection. In clinical trials, mycophenolate mofetil has shown a superior efficacy to other antimetabolites like azathioprine in terms of preventing rejections. For this reason, for nearly 3 decades, mycophenolate has been the antimetabolite of choice for most US transplant centers. This encompasses a large population. For example, there are 20,000 new kidney transplants every year in the US, and more than 90% of these patients would receive MPA products as one of their maintenance immunosuppressive agents. And any side effects will have a huge impact on our healthcare system. The most common side effects of mycophenolate mofetil are diarrhea, stomach upset, nausea, and vomiting, as well as leukopenia. To alleviate the gastrointestinal side effects, enteric-coated mycophenolate sodium tablets came out to the market in 2004. While it showed the similar efficacy to mycophenolate mofetil in terms of preventing rejections, the beneficial effect on GI side effects, however, has not been consistently demonstrated. Currently, mycophenolate mofetil is only FDA approved for the prevention of rejection in allogeneic renal, hepatic, and cardiac transplant recipients. And enteric-coated version, the enteric-coated mycophenolate sodium, is approved for its use in renal transplant. However, they are often used off-label in lung, pancreas, small bowel, and composite tissue transplant. And in addition, it's used for the treatment of autoimmune diseases steadily increases as well, such as lupus, rheumatoid arthritis, inflammatory bowel disease, such as Crohn's disease, inflammatory eye disease, and other autoimmune kidney and skin disorders.
Thank you so much for that information. I particularly enjoyed the history of mycophenolic acid. So we now have a drug that's been on the US market for over 25 years. How come the FDA has only recently put a Rems program in place for mycophenolic acid?
Sure. The need for a REMS program stems from the observed congenital malformation and negative pregnancy outcomes with mycophenolate. Of course, it takes time to discover these side effects. The first case report of human teratogenicity of MPA was described in 2001. A child was born with hypoplastic nails and shortened fingers to a mother who has been exposed to mycophenolate. Many other subsequent cases came out as well, describing a range of congenital malformation in children who were born to a mother who was taking mycophenolate during pregnancy, including hearing loss, cleft palate, heart defect, and various malformations of the face, head, kidneys, limbs, and esophagus, etc. In 2006, famous, or should I say notorious, NTPR, National Transplantation Pregnancy Registry data, published their findings in 33 MPA-exposed pregnancies, reporting 45% of miscarriages and congenital malformation in 22% of the remaining live-born infants. Additionally, post-marketing data of 77 female patients exposed to mycophenolate during pregnancy between 1995 and 2007 also reported 32% of spontaneous abortions and 22% of a malformed infant. Both of these studies agreed, suggesting the rate of miscarriages associated use of MPA in pregnancy ranges up to 30 to 45% and over 20% for congenital malformation. This rate of aberrant fetal outcomes is overwhelming when considering the overall rate of congenital malformation previously reported in the offspring of transplant patients was 4 to 5%, which was comparable to 3% in the general US population. It is not certain if the dose of MPA or the duration of exposure matter. And the important question arose after these observations if discontinuing the medication ahead of the time as a planned manner has any benefits in terms of preventing negative pregnancy outcomes. Many cases reports suggested that better pregnancy outcomes when MPA was stopped prior to conception. The NTPR, again, National Transplantation Pregnancy Registry Annual Report, compared pregnancies conceived on MPA to those where MPA was discontinued prior to conception in kidney transplant recipients. The woman who discontinued MPA prior to conception had a significantly higher rate of live birth and lower rate of birth defects. The rate of miscarriages in pregnancies with MPA exposure was as high as 48% again, compared to 20% in pregnancies where MPA was discontinued at least 6 weeks before conception. So you can see the discontinuation of the MPA can reduce the chances of negative pregnancy outcome, and proper contraception is needed in females of reproductive potential during MPA use and for at least 6 weeks following discontinuation of the drug. Based on this data, in 2007, the FDA changed the MPA's pregnancy safety category, whose system is obsolete now, by the way, from category C to category D, indicating there is evidence of human fetal risk. The potential benefits may warrant use of the drug in pregnant women despite the potential risks. The FDA also ordered the manufacturers add black box warning in the prescribing information and mandated the medication guide to be distributed to every patient at every field at pharmacy to raise the awareness. And finally, in 2012, the FDA approved a single shared Rems program for all MPA-containing products. And since it was initially created, it went through multiple modifications. Rems, short for Risk Evaluation and Mitigation Strategies, program is implemented as part of the FDA Amendment Act of 2007 to ensure that the benefits of an already approved medication outweigh the risks associated with using it in the wake of post-marketing cardiovascular toxicity crisis of the medication called rofecoxib. The goals of the MPA Rems are to prevent unplanned pregnancies and fetal exposure to MPA by educating prescribers, female patients, and other healthcare professionals on the risks of gestational use of MPA and the need of prevention and planning of pregnancy, and also by collecting information on pregnancy outcomes using a pregnancy registry created for all MPA containing products. When you go to the Mycophenolate Rems website, you can see the responsibilities of the different stakeholders. For example, here are the roles of the providers in the MPA Rems program. Document your training in the Mycophenolate Rems, educate female of reproductive potential on the fetal risk and contraception, check pregnancy status immediately before and 8 to 10 days after the initiation of an MPA product. Report any pregnancies that happened while on a MPA therapy or within 6 weeks of the drug discontinuation to the Mycophenolate Pregnancy Registry. Considering that the number of adult female organ transplant recipients totaled nearly 10,000 a year, and the high prevalence of MPA use across all organ transplants in the US, the patient population affected by this Rems program is fairly large, and there's also unknown number of patients at risk receiving the MPA products in an off-label manner. It is also noteworthy that the MPA Rems program does not require prescriber training or negative pregnancy testing as prerequisites to dispense the drug in order not to hinder patients' access to the medication. At this point, we do not know if MPA Rems would minimize the number of unplanned pregnancies while on mycophenolate or improve pregnancy outcomes, but it is definitely a step forward to it.
That's an excellent overview, Dr. Kim. Thank you so much. It seems like the Rems program is really meant for female recipients. Does the Rems program apply to male patients taking MPA?
Not specifically, that is a great question, but the prescribing information for MPA recommends sexually active men and their female partners use effective contraception methods, while the male patient is receiving an MPA product, and for at least 90 days post-treatment. I'm not very clear how 90 days of the washout period was suggested, as there seem to be no observable risks of negative fetal and pregnancy outcomes when a man using MPA fathers a child.
Thank you very much, Dr. Kim, for joining me today. This topic is so important in learning the basics of mycophenolic acid, the different preparations, the history of this drug's use in transplantation and other autoimmune diseases has been excellent.
Thank you again for letting me participate in this wonderful initiative. I work with the heart transplant recipients. We use MPA products all the time. I definitely see a gap between the knowledges of our providers about how to use it, and in terms of helping patients not reject the organ, but we seldom think about the pregnancy risks. We definitely do not routinely check pregnancy tests before starting MPA products, and definitely not the subsequent pregnancy tests. Fortunately, population I'm working with is usually the older male. As you can easily imagine, that's the population we'll see in the cardiomyopathy group. So I definitely feel the need of this Rems program, and yeah, we have trained our providers through Rems when the mycophenolate Rems was initiated in 2012. I definitely think the continuous effort to train them is definitely important.
No, agreed. It's like anything else. When you become comfortable with prescribing drugs in a certain way, especially a drug that's been used for almost 30 years, that teaching an old dog new tricks can be difficult. So any further education that we can implement to help our clinicians who use mycophenolic acid on a regular basis to educate their patients and try to maintain control over MPA use in patients willing and trying to get pregnant is super important. Now, by way of summary, I'd like to offer a few SMART goals to our audience, which are specific, measurable, attainable, relevant, and timely. Identify the serious pregnancy and fetal risks related to mycophenolate use. Familiarize, or in a lot of cases, refamiliarize yourself and your healthcare providing team with the mycophenolate Rems program. Stay current with accruing data from registries and apply lessons learned to help aid in the care of your female patients of childbearing potential. As I mentioned, this is the first of 3 CMEO snacks on the mycophenolate Rems. Please visit the virtual education hub at www.cmeoutfitters.com to participate in parts 2 and 3. And don't forget to complete the evaluation to claim credit for today's activity. Thank you for your attention. We hope you will find the information useful in caring for your own patients.